we're so glad that you guys joined us this evening. My name is Emily Russell, and I have the privilege of working here at Clearview as the Director of Marketing and Business Development. And I'm so excited that you guys are here tonight. So if you have shoulder pain, raise both your arms like this. No, I'm just kidding. My guess is if you have shoulder pain, that's why you're here this evening, and perhaps that motion can be a bit painful, if not impossible at times. So we are so excited to have with us one of our premier orthopedic surgeons here at Clearview, Dr. David Harkins. He is a fantastic and phenomenal doctor. I've heard many of you mention that he's your doctor. He's my doctor. He operated on my knee last summer, and it's great. I can do cartwheels now. It's wonderful. So without any further ado, I'll just turn it over to you, Dr. Harkins.
Don't rub it on too thick.
That's right. I'll try not to. I'll try not to. All right.
All right. Well, thank you so much for coming tonight. I want to thank Emily and Clearview for hosting tonight, for helping to put this together, and for my team with Christy Ellis passing out some napkins and other things back there in the back. She runs the show out here for us in this area, and for Jocelyn Wyckoff, who couldn't be here tonight. But first of all, I want to thank you guys for coming out tonight. When I got done with surgery today and walked outside, I thought, well, no one's going to show up tonight. So thank you all for braving the weather tonight and to come out to hear me speak, and hopefully say something that speaks to you and brings you back. Just a little bit about myself. I've now been in Monroe and the Walton County area for a little over 10 years now. And I see some current patients and former patients out in the audience tonight, and I appreciate you coming. We've enjoyed living here and providing good service to the community for the past 10 years. First, I started opening up a orthopedic practice on my own called Providence Orthopedics. Joined shortly thereafter by Dr. Shane Smith. Recently, about 5 years ago, we joined teams with Athens Orthopedic Clinic and have been growing strong ever since. We currently have locations all over. I go to 4 of them here in Monroe, Covington, Loganville, and in Snellville. So we're just about anywhere you can be, and if you need to make an appointment, I think we have an office near you. So tonight I want to talk a little bit about the upper extremity and shoulder. It's kind of near and dear to my heart. It's what I trained in. I do a little bit of everything in orthopedics other than spine. I let my partners take care of the spine. But I do a little bit of everything, sports medicine and total joint replacement. But I am a specialist in shoulder and elbow problems. I did some extra training in my training called a fellowship, where I trained with some premier surgeons out at Baylor University Medical Center in Dallas, Texas, for a year after I finished my residency program in nothing but shoulder problems. Did a lot of shoulder replacement surgery that year, as well as rotator cuffs and other issues. So tonight I'd like to talk a little bit about shoulder pain, but specifically as it relates to shoulder arthritis. So we start just with a little overview of the anatomy, and I know this picture on the left here is not all that clear, so I did bring a model with me, but that's basically showing the bony anatomy of the shoulder. And the shoulder is essentially a ball and socket joint. So you've got the ball, which is your humerus. The top of it makes up the ball of the shoulder, and then you have the socket, which is the curved area here on the scapula or the shoulder blade. And together they make up the shoulder joint, along with the muscles and ligaments that hold it in place. And that up here on the right, you'll see some of the rotator cuff muscles and some of the other ligaments and muscles that help hold the shoulder in place. But here in the front, you've got one of the rotator cuff muscles, and on top, the one that normally tears, called the supraspinatus. And the rotator cuff is actually made up of 4 muscles. They surround the shoulder, they support the shoulder, they force the ball into the socket, so then the bigger muscle, the deltoid, can lift the shoulder up over your head and help rotate the arm around. Right here you see the biceps muscle, and it sends a tendon up into the shoulder, on the front of the shoulder, and it actually attaches to the top of the socket there. I don't know if all of you can see that, but we can pass this around later. So that's just kind of a brief overview of the shoulder anatomy. So when patients come to my office, they don't typically come and say, I've got arthritis in my shoulder. They come to me and they say, I've got shoulder pain. And it's up to me to figure out what's going on in the shoulder. So here are just a few issues that can be going on in the shoulder, and I've got to figure out what the diagnosis is, and then figure out the best treatment options. So most of you have heard of slap tears and instability of the shoulder dislocating, some bursitis or impingement, which is a very common problem, rotator cuff tears, some fractures, and even essentially osteoarthritis of the shoulder. So just some pictures of those. On the upper left there's a rotator cuff tear. Certainly a very common complaint in patients older than 50. About 1/4 of the population has a rotator cuff tear. If you're older than 70, about half, 50% of people have rotator cuff tears. And so I see a lot of rotator cuff tears, and I fix a lot of rotator cuff tears. In fact, today I fixed 2 of them. Fractures, proximal humerus fractures or shoulder fractures are pretty common. I do a lot of those. Shoulder dislocations down here. Shoulder impingement is kind of a consortium of several things. You can get some rotator cuff tendonitis, some inflammation in the bursa, which is a potential sac of fluid that protects the rotator cuff and the outer bones of the shoulder. As you raise your shoulder up, it gets pinched in between the top of the shoulder here and the top of the shoulder blade, and that can cause bursitis. And so that's essentially what shoulder impingement is impinging the shoulder bursa between these 2 bones and causing shoulder bursitis. And we can talk about that a little bit if you want to later on, but we'll press on with the shoulder arthritis talking. Down here is an x-ray of shoulder arthritis, what that looks like, and kind of a drawing of what that means. So essentially, God gave us a protective covering of cartilage on all of our joints, and when that wears off, then we have shoulder arthritis. So as we wear through that protective covering of cartilage, we eventually get down to bone-on-bone arthritis, and we're rubbing bone on bone. So it's not just the knees and the hips that we're talking about anymore, it's the shoulders as well. And shoulder arthritis is becoming more and more prevalent. So typically when patients come in complaining of shoulder pain, I listen to what their signs and their symptoms are, what makes them hurt, what brings on that pain, what makes it worse. Then I do a physical exam, and then take some x-rays, and with that information I can tell you with most certainty what's going on in your shoulder. If you come in with an x-ray like this, there's no doubt about it. You've got shoulder arthritis. So what is arthritis? It's osteoarthritis. Essentially is what I just said. It's wearing out that protective covering of cartilage so that you've got no more barrier in the joint itself, and you're rubbing bone on bone. That creates pain, that creates inflammation in your joint. It is associated with wear and tear. It's typically not associated with an injury, although you can have an injury and have resultant arthritis years later. People that dislocate their shoulders multiple times typically will develop some arthritis later. If you have surgery for shoulder dislocations, you can develop arthritis later on. If you have a rotator cuff tear that goes untreated, you can develop arthritis later on. Typically with osteoarthritis, it develops in the 50s and 60s and later in life, but it can develop earlier in life. I do have some 40-year-olds and younger with pretty significant shoulder arthritis. Some are from injuries that they sustain while playing football or lifting weights or whatever, but there's a propensity of hereditary arthritis as well, that we can get this from mom and dad and on down the line. So there's some of that as well. And, some people are born with problems that lead to arthritis later on as well. But typically, as you wear through the cartilage and you're rubbing bone on bone, that causes pain with any range of motion. Anywhere you try to move this shoulder, that causes pain. There's really not a whole lot of relief from that. The arthritis, the bone-on-bone rubbing, also causes inflammation in the joint, and it is progressive. It will get worse. Once you develop arthritis, it is going to progress. I see people all the time who tell me, well, I thought it would just get better, so I didn't do anything about it. And it's just gotten worse and worse and worse, and now I can't hardly move my shoulder. But that's pretty much the general progression of arthritis. It will progress, it will get worse, especially in the shoulder, as you try to guard your shoulder and stop moving your shoulder to eliminate the pain or help the pain. That causes stiffness in the shoulder. And so as it hurts to move your shoulder, so you stop moving that shoulder, and then you develop more arthritis and more stiffness in the shoulder, which makes things worse. It compounds things. So what are the treatment options for arthritis? As I said before, rubbing bone on bone in the shoulder, or any joint for that matter, causes pain and causes inflammation. So one of the things that we use, all of our tricks in our bag to treat arthritis deal with getting the inflammation down, which in turn gets the pain better. So we use anti-inflammatory medications. Those are either taken by mouth, or now in the past couple of years they've come out with some anti-inflammatory medicines that are in a gel form or a cream form, and you can rub that on the shoulder and it'll penetrate through the skin down to the joint, and very little of it will go down and will go through the bloodstream, and none of it goes through the GI tract. So if you have an ulcer, you can still have some anti-inflammatory medications. So that's provided a good bit of relief for people that couldn't take anti-inflammatory medicines before. The other thing that I'll typically do is a steroid injection. And steroid is essentially a high-powered anti-inflammatory medicine. So it's going to get to the root of the problem. You're going to inject it right into the joint, into that between the ball and the socket, which is where the inflammation and the pain are coming from, and inject the steroid medicine there to decrease the inflammation and help with your pain. Now these are not going to get rid of your arthritis, but they're going to help for a while. It is a band-aid of sorts, but eventually you can come back to this over and over. So you can inject the shoulder about every 3 to 4 months to decrease the inflammation, decrease the pain. If you're not ready to have surgery for your shoulder, that is an option. So you don't want to do that forever, but you can do it until you're ready to have surgical intervention. And also physical therapy. As I mentioned before, most people will stop moving their shoulder very well, and as they stop moving their shoulder, they get stiff. Also the bone spurs that are created with glenohumeral arthritis or shoulder arthritis prevent motion as well. Typically you're going to lose the motion first here in what we call external rotation. Instead of being able to turn out 90 degrees like this, you'll start noticing I can only turn out to 60 degrees. I can only turn out to 45 degrees. 30 degrees, and eventually 0. And I've even seen some people that couldn't even get to 0. 0 is straight out in front of you, or neutral. So as you progress through this process, the more you create friction in your joint, the more your body will create more bone, and that's called bone spurs, and that's going to prevent your motion as well as the pain and inflammation. So the focus of physical therapy is essentially not to eliminate your pain, is to try to maintain as much motion as we can before surgery. If you can maintain your motion, typically you can prolong having to have surgery. When your motion starts to decline, you're leaning towards your options are getting thin. So finally, and last but not least, in the cascade of treatment options for shoulder arthritis is shoulder replacement. Now, essentially, you've worn out your joint, so you're going to replace the joint. And the shoulder replacement was actually thought of or performed before knee and hip replacement. It didn't turn out so well the first time around, but that's the natural history of it. Now we've gotten much better over the years, and that's why I'm here talking to you about it now. But shoulder replacement essentially will relieve the pain. It gets rid of the arthritis. So you're cutting out the arthritis and replacing it with metal implants and plastic implants that will take the place of your shoulder and become your new shoulder. So that in and of itself gets rid of the cause of the pain, and it's pretty predictable. The only reason really though to proceed with shoulder replacement is for retractable pain. You can't get better with anything else we've tried. We've tried some anti-inflammatory medicines, and at first they'll help. Eventually they'll stop working for you. The intra-articular steroid injections. At first you'll get some pretty good relief from them. Eventually they will work less and less, and eventually not help you much at all. The physical therapy, instead of helping you, it's causing some pain now because it hurts to move your shoulder in any planes. That's the time that you want to talk about shoulder replacement. And that's really the reason to do shoulder replacement, is get rid of your pain and to treat your motion and try to improve your function. So like I said, the first shoulder replacement was actually performed in 1893 for, of all things, tuberculosis. And it didn't turn out all that well, had to be taken back out. And for a while, people steered away from shoulder replacements, but it was really popularized by a very famous orthopedic surgeon by the name of Charles Neer in the 1970s and 80s. And he really pioneered shoulder replacement as we know it now. He developed the prostheses that are essentially the same as he initially developed, just with some modifications since then. He did most of the initial studies that we now have that are considered the landmark studies, and the guys that he trained are now in the big programs training guys up under them to come out replacing shoulders. There have been multiple advancements over the years, especially since the 1970s, but really in the past 10 years I've seen a lot of advancements with shoulder replacement surgery. Used to, we could only tell people that they would last for about 10 years, and that's all the data we had on shoulder replacement surgery. But now the recent articles are showing pretty good survival rates at 20 years. And so that's a huge deal. It's the same thing with hips and knees. As the advancement got better and better and more people put them in and made advancements in the designs, they're lasting a good 20 years now as well. And so we've gotten there with shoulder replacements now there finally as well. So that we can tell people now there's a pretty good survival rate at 15 years on the order of about 85 to 90%, and the same at about 20 years. So they're gaining in popularity, and that's a large part because of guys like me that are doing shoulder fellowships and coming out and doing shoulder surgery. People are finding out about it, and more people are interested in it now. No longer do you have to live the rest of your life with the bum shoulder that hurts all the time. You've got something you can do about it now. So with shoulder replacement, like I said before, it is very predictable in the amount of pain relief you get from it. I can typically replace a shoulder. They'll typically stay one night in the hospital. I can walk in the room the next morning, and the pain they had before surgery is gone. And I have not had one person tell me the difference. So I typically will ask that. And they will have some pain from surgery, but the pain that they have is different. So it predictably takes that arthritis type pain away immediately. And it restores motion. It puts things back to where they need to be. It restores how the shoulder was put together by God in the first place, albeit not your natural parts. But it allows the body to take over. Once you go through physical therapy again, to get stronger, your motion improves and your function improves. So this is just a few pictures. This is a shoulder before surgery. You can see that the joint here is not smooth anymore. It kind of looks like a pothole in the road that's been worn away. It was painful all the time, and we went and replaced the shoulder joint, and they did very well with that. And here's a young lady who's very happy with her shoulder replacement, and you can see the amount of motion that she got after that. So the post-operative motion in this shoulder looks like the other shoulder. So her post-operative motion matches her pre-operative motion of her other shoulder. And so that's the kind of motion that you could expect to get. Now, not everybody gets there to full motion, but a great majority do. And if you can relieve your pain and restore motion to your shoulder again, most people are pretty happy with that. So typically, when I do a shoulder replacement, it's a one-night stay. Most people are going home the following day. Sometimes they'll stay for either medical reasons or some pain in the shoulder for a second night. Typically, I'll put patients in a shoulder immobilizer. There is one of the rotator cuff muscles I have to take down off the bone and then repair it at the end of the case. So that muscle has to heal, so we have to give it some time to heal. I do put you in a shoulder immobilizer for 6 weeks. That allows that muscle to heal down. Without that muscle, you won't have the force couples around the shoulder to be able to get the motion that you want. So that muscle needs to heal down during that first 6 weeks. And then after that, I put you into physical therapy, and we'll work on number 1, getting the motion back, and then number 2, getting your strength back to restore your motion. And that's pretty much all I have for you. I'm happy to answer any questions. Hopefully I explained things well enough for you to make an informed decision. So I'll open the floor to any questions right now. Yes, ma'am.
What are some other reasons you might need to have a shoulder replacement?
Well, there's a variety of reasons. For a standard shoulder replacement, it's what we just talked about. Now, if you have a rotator cuff tear that it cannot be repaired anymore, we can do a shoulder replacement that's different from what I just described. It's where we put the ball on the socket and the socket on the ball, and I think I have a picture of it. Here. So this goes on the socket, that ball, and then the socket goes on the in the humerus. So this becomes the socket, this becomes the ball, and then they rotate, they fit together like that, and that's how you get your motion. pretty good motion, restores the motion and the function pretty well with that prosthesis.
Why would they do that? Why change?
Well, we had no other. Well, it's not changing just a standard total joint or a total shoulder. This is someone who does not have a rotator cuff anymore. So this compensates for a rotator cuff. So you don't have the muscles holding the shoulder in place anymore. So the shoulder will rise up. So it'll the ball will come in contact with the top of the
process. Yeah.
Correct. And so you lose the motion. And most of these patients, when they get further along, they don't really have much motion. So they can't really move their shoulder anymore. So this has provided us with a way to treat that we couldn't do until 2004, excuse me. And so that compensates for someone who does not have a shoulder rotator cuff anymore.
What does visco supplementation consist of?
Well, viscose supplementation, if you do the injections you're talking about, there are a variety of companies that make a gel. It's mostly made in the lab, depending on which company you go with. It's essentially made to be consistent with your joint fluid, and injecting viscose supplementation or a gel into your joint or add more fluid into your joint. It's essentially like putting oil in your car. You put oil in your car to decrease the friction in your engine parts so they don't wear out. You put viscose supplementation into your joint to increase the amount of fluid you have in the joint, to decrease the friction you have in your joint, to hopefully help keep it from wearing out, and to decrease the pain that way.
Strictly temporary.
It is strictly temporary, and you can do it once every 6 months, but typically it doesn't last too much longer than that. It can. I have that I've done that for, and they've come back a year later and just started to have pain again. So, yes, sir.
What provides lubrication? Now that is an actual replacement.
No, this is just a natural shoulder.
So that's just, you haven't got an example of, a physical example,
Right up here. Yes, sir.
but not.
Not with me. Not with me.
Okay, well, what provides lubrication for that ball and joint?
Your body. So as we close the shoulder up, your body will start producing joint fluid again. And so it never stops that process. So when you have, even with the shoulder replacement in there, your body will produce joint fluid, and so that the more you move your shoulder, the more joint fluid your body will produce to keep the friction down in there.
If you have your, after you do this, and you have your shoulder, arm in the thing, immobilizer, thank you. You said the 6 weeks, does that mean you got to keep your arm like this for 6 weeks?
Yes, ma'am. You want to allow that muscle to heal back down to the bone. So when we do a shoulder replacement, I have to take this muscle off the bone. So that's called your subscapularis. And I take that muscle off the bone. At the end of the procedure, I repair that muscle back down to the bone with stitches. And that's got to heal, so we give that time to heal. And it takes on the order of about 6 weeks to do that.
How can you put stitches in a bone?
I drill holes through the bone.
Very careful.
Yes, ma'am.
You just had to ask.
With it being immobile for that length of time, what would keep it from not being a frozen shoulder?
Well, our trusty physical therapist in the audience there. Your body is going through the healing process, and you may develop some stiffness during that 6 weeks. But I would rather have stiffness there to start with than an unstable joint. So once we've got the subscapularis healed down, then we can start the range of motion process. And typically with physical therapy, we'll start with just passive range of motion the first few times, and then we advance that to active assisted and active range of motion. What that means is we start with the therapist doing the motion for you, and then we advance you to pulleys and using tools to start getting that motion back, and then eventually with you doing the exercises. And so once we get that motion back, then we can progress on to strengthening as well. But
It's a different process too. You're being immobilized to protect something
Right.
that he's repaired. The frozen shoulder, I don't think it's really well understood still why it starts, but that's a process where the joint's freezing, you're getting less and less motion, and then it starts thawing. Once they take you out of the immobilizer, then you're allowed to start moving passively, then active will do. Normally, you're gonna get that motion back.
Right.
Not until the joint decides to unfreeze in a frozen shoulder are you gonna start getting motion back.
right. Yes,
I
ma'am.
had surgery on my arm from a break,
Mhm.
and as you said, they sewed the bone back together. And I went through therapy, and this has been a year. April was a year ago, and I'm still having a lot of pain.
Okay.
Is there any answer to? I do physical therapy. Well, I say therapy. I go to fitness and I use my arm, with weights. Am I going to do any damage to it because I'm doing all this weight, using these weights, or am I keeping it mobile by doing these weights? I don't want to make it any worse,
Right.
but I'd like for it to get better.
Yeah, I don't think you're going to do any harm to it. Not usually. Doing exercises will help you stay mobile, get more motion. There are some things with fractures to the shoulder that can limit motion, and sometimes it takes looking at that and figuring out why you're still having pain, why you're still having lack of motion and strength in your arm. Doing some x-rays, possibly some other imaging studies to figure that out, and certainly an exam, and then figuring out what we could do about it. There are some options for us.
I went through an occupational therapy evaluation, and they determined that with workers' comp, they couldn't do anything else to make it any better. And so they put me on disability,
Sure.
took me off my bus. And I keep thinking that as time goes on, that the pain will get less, but it's not. It's just getting worse. Not unbearable, but not as. I still have a lot of pain.
I'd be happy to take a look at it for you. Try to figure it out. There's certainly a reason why you keep having pain,
Yeah.
and sometimes it takes converting what you might have in there, hemiarthroplasty, to a reverse total shoulder to get that pain better and get the motion better. But it just takes taking a look at it and seeing what's causing your pain and trying to see if we can solve that for you.
There is help though.
There is help.
I have a question about that. So if you have enough force to cause the bone to break, and let's say you're doing an ORIF, are you typically visualizing the rotator cuff and doing anything about that if it appears to be disrupted? Because
So-
that's what I tell them. When I have a patient like that, I say, well, they fixed the bone, but there's a good chance that there was some soft tissue damage, and that's what's causing your pain now.
And that could be. And so just to clarify, an ORIF is basically using, it's open reduction internal fixation. So if you have a fracture to the proximal humerus here, and it's broken into pieces, sometimes you can put that back together with a plate and screws. And you do have enough visualization to look at the rotator cuff while you're in there, and you can put some stitches into the rotator cuff. There are some other issues with that process. With putting screws into the proximal humerus, you can damage the blood supply, or the blood supply can become damaged by the process of you breaking the shoulder, and you can develop an area of bone non-healing in here, and even bone death, and so that it collapses. So that can be a cause of pain, and I've seen that a few times. The rotator cuff can tear later, so it doesn't have to tear during that initial incident. It could tear later and cause pain, or it could tear partially during that fall, and you not recognize it or not see that, and then it advance after surgery as well to a full thickness rotator cuff tear. There are a variety of reasons that it could be. It could be, just some frozen shoulder as well, just from the trauma. That can develop as well.
How does the avascular necrosis or the non-healing part present?
Typically with pain. You're
I'm
gonna
just
have
asking to help me so I know when to send people back.
you're gonna have a patient that has that will typically come in with pain, and it's a pain that just doesn't get much better. Yes, you just can't relieve the pain because it's more like a pressure in your shoulder. And it takes, you can take anti-inflammatory medicines. You can do some other things, but essentially, eventually, you're going to need a shoulder replacement for it to get rid of that area.
So are they looking at doing hemiarthroplasties now when you have that multiple?
Yeah, I mean, we've done a whole host of articles on hemiarthroplasty versus total shoulder, and I actually wrote one myself, and the studies all show that total shoulder actually does better in the long term than the hemiarthroplasty does. So yeah, years ago we were doing hemiarthroplasties, but probably in the last 10 years it's trended towards doing total shoulders. So much that not too many people do hemiarthroplasties much anymore.
When you have that immobilizer home,
You don't like that
you take a shower, you take clothes, anything like that?
No, we show you how to work around the immobilizer. My nurses are very good at talking to you about how to put your shirt on and off, and how to take your shower. And essentially, once the skin heals up, you can get in and out of the shower. That's typically 7 to 10 days that I'll take any stitches I might have there out in the office, and I'll show you how to get in and out of the immobilizer to take a shower. It's usually a 2-man job. You do unstrap the immobilizer, slide it off, and I tell people to put an empty 2-liter Coke bottle underneath your elbow, and that holds the arm out from the side, and you can wash up underneath your underarm pretty easily. And that prevents you from having to elevate it up when you really can't do that very long.
My situation here is just a little grinding and it's sore. Is that basically all right?
Could be. It could be bursitis as well, a rotator cuff tear.
That's what I was taking the injections.
Well, that's what I would typically start with, whether you had bursitis or impingement, or rotator cuff tear, or arthritis. I'm typically not going to jump to surgery unless I'm taking you down the road of treatment options and you're not getting better. So I would typically do a steroid injection either the first or second time I saw you, and try to get that inflammation down for you as best I could. Yes, sir.
If a person is in a physical training environment, you familiar with Alcovy Fitness Center?
Yes, sir.
Yeah. Well, she was in that and doing real good, and her shoulder started bothering her. And the doctor, I don't know which one, but the doctor told her that she should not put weight and range of motion and strain on it. Seems to me like that would cause it to freeze up.
Get stiffer. And it can, but what they might be talking about is doing weights.
Even light weights.
Well, I would tell you to do as much as you can do, because when you stop moving your shoulder, that's when it starts getting stiff, and that's when it starts going downhill.
Okay, would you use pain as a measurement?
Absolutely, absolutely. I tell my patients if it hurts, don't do it. Unless I'm making them go through physical therapy and they've gotten to the point where they need to push through some of that hurt, you know, to get to some better results. But yeah, if you're before you come see me, or even during that the first conservative treatment route, do what you can do. Try to stay as active as you can. If it hurts, don't do that. You know, stay away from that. So if heavier weights are hurting the shoulder, then stop doing heavier weights. Do smaller weights and smooth reps, but increase the amount of reps you do, because that increases the strain on the shoulder and actually will build the muscle.
Well, she was being trained or worked with by a therapist, trained therapist, and when she told the therapist, she'd been, what, a year or so? When she told her what the doctor said, she said, well, I can't help you if you are ordered not to.
You can't do anything.
exercise. Yeah.
Sure, I mean, I can understand that. But I would tell you, try to stay as active as you can. What I see most of my patients, if they stop being active, they stop trying to get some exercise, that's when they, you know, typically need more treatment because they have more pain and more stiffness.
Is there a stretch exercise, range of motion that you can do to help?
There's several stretching exercises. I have a list of them in my office that I'll typically hand people so that they can either do those on their own, or I'll have them go see the therapist so the therapist can show them some stretching exercises to help try to maintain and regain as much motion as they can.
Do you advise them against any particular exercises in the gym?
Well, the biggest thing I tell people is not to use heavy weights, to use lower weights, higher reps, but instead of the herky-jerky motions, trying to throw weights up there thinking that that's building your muscle, that's actually a lot of times causing more harm than good. I'll tell people, you know, do nice, easy motions. So as long as you're doing slow, easy motions with the right amount of weight, most of the exercises are okay. It depends on each person. You know, there are certain exercises, you know, bringing the weights behind your neck, especially dumbbells, that, you know, you have to balance. So certainly choose your weight carefully so that you're not overdoing it. You can certainly damage your shoulder pretty easily trying to do weights too high for yourself, too heavy.
So I don't really understand rotator cuff stuff. So if you get little tears and all, will they heal themselves, or are they just there forever?
No. Rotator cuff won't heal. So the best option we have for a rotator cuff tear is surgery. It's putting it back.
So how about you have little tears? I mean, how bad does it have to be?
She's talking about paying for the surgery.
So with rotator cuff tears, if you have a partial rotator cuff tear, so it's not a full thickness tear, those typically don't need surgery unless they are about to become a full thickness tear. So, and we've got measurements we can do for those and tell you which ones are which. Typically, if they're greater than 50% tear of the thickness of the tendon, we're going to lean towards surgery, especially if you're not getting better by conservative measures. But the rotator cuff, when it attaches out here, so it comes from here and attaches out here. And so as it tears off, it peels off and pulls away from the bone. And so it does not have the ability to reach back out and grab the bone and heal back to itself. So the best option that we have for that, once you've torn the rotator cuff and it's pulled away from the bone, is surgery. And that typically we used to do big incisions for the shoulder to repair the rotator cuff. Now we do them all through small incisions. I typically do little poke holes around the shoulder and use instruments that are smaller in diameter than my pen to put your shoulder back together, your rotator cuff back together. So essentially, I'm going to go in with a camera and clean up all the bone spurs and clean up all the inflammatory tissue, and then take your rotator cuff. I'll put an anchor down into the bone, which dissolves over time, and that has stitches attached to it. I'll pass those stitches through the rotator cuff and I'll tie it back down to the bone. Now, along with, we're back to the immobilizer again. With that surgery, the biggest thing is the shoulder immobilizer, and it takes about 6 weeks for that rotator cuff to heal back down to the bone as well. And so you're in a shoulder immobilizer for 6 weeks. Now the difference is with rotator cuff surgery, I can put you into physical therapy right away. So studies have shown that early passive motion, early motion to the shoulder after rotator cuff repair is no different if you stay still for 6 weeks and do nothing. So it's not putting your shoulder, it's not putting your rotator cuff any you're not going to re-tear your rotator cuff just by going through physical therapy. Now the caveat to that is letting the therapist move your shoulder. So the first 6 weeks is all passive motion, which means that the therapist is moving your shoulder for you. After that first 6 weeks, then you're able to move your shoulder yourself in physical therapy, and you start doing those exercises that the therapist was doing for you.
So how do you do this? How do you tear this thing?
The majority of rotator cuff tears happen just from wear and tear over the years, just reaching up over and over and over. The majority of patients are not tearing the rotator cuff from a fall. If you're younger than 50, it is typically from a fall. If you're older than 50, it's typically not.
What if you're a pitcher for the Braves?
Well, if you're a pitcher for the Braves, please come see me.
How do you see a tear? You can't see it on a regular X-ray, right?
Correct. But I would take an X-ray just to look at your shoulder to make sure you don't have the arthritis that I showed before. If not, then I would examine you. If you have weakness, typically in this position, if I can push your arm down against you trying to resist me, you've got a rotator cuff tear until proven otherwise. And an MRI would show that. An MRI is similar to taking X-rays, but it'll show you all the soft tissues. So it'll show you this picture on the right instead of this picture on the left.
But if you have a tear, the pain should not be there for a while and then go away for a while, should it?
It can do different things like that, especially if you're taking some anti-inflammatory medicines. Now the anti-inflammatory medicines will decrease your inflammation, and it may go away for a while, it may get better for a while, and then just one day you notice it come back. Same thing with the injections. The injections may make your pain go away for a while, but it may come back because this problem is still there.
Is there any chance that, like, if you have a lot of neck involvement, can that cause shoulder pain some way?
It can cause shoulder pain as referred pain, but your neck, having a problem in your neck is not typically going to cause pain specifically coming from your shoulder. So it's two different things. I'll see a lot of patients that come in and say, my shoulder hurts me. I have shoulder pain, and when you start asking some questions, start figuring out, well, this sounds like it's coming from the neck. So pain that travels down the arm, or numbness and tingling that travels down the arm, is not from your shoulder. It's from your neck, from a pinched nerve in your neck. The pain that stays here at the shoulder and is worse with certain movements, that's typically shoulder pain. Now one can cause the other, in that when you have shoulder pain, you can have pain come up into your neck because of your muscles, because they're connected from your neck to your shoulder, and vice versa.
So tight sometimes,
You get spasms, right? And that can cause a lot of people think that their shoulder, it's the shoulder that's bothering them when it's really the neck, and vice versa.
And you can have a problem in both areas too.
Right.
Did she say?
How does
And you have a
cortisone
problem in both
injection
areas.
help?
So,
Cortisone essentially is just a high-powered anti-inflammatory medicine. So it's going to decrease the inflammation in that area that you put it in. So if you inject it above the rotator cuff, it's going to decrease the inflammation to the bursa and the soft tissue that's above your rotator cuff. So if you inject it into the joint, it's going to decrease the inflammation to all the tissues that are in the joint.
Okay. How last does it, excuse me, how long does it last after you inject it?
Sometimes time you get home,
It's different
If
for
you reduce
everybody.
the inflammation, seems like a day or two later, it could come back.
It could. It's different for everybody. Now, typically it starts working in about 3 or 4 days, but for some people it lasts 6 weeks. For some people it lasts 6 months. For some people it lasts 6 days. So it's different for everybody, and a lot of times it depends on how far advanced your arthritis is. Now, if you have gotten several injections along the way, and this is say your 3rd or 4th or 6th or 7th injection, it may not work as far as someone who's getting their first injection. So it's gonna, as time goes on and your arthritis progresses, those cortisone injections are going to work less and less for you.
Would a cortisone injection help my shoulder?
Possibly. I would say it most likely would. I would certainly need to take a look at it and see what's going on there to let you know for sure.
After your cortisone injection, is there a therapy that can prolong, once it reduces the inflammation, that would prolong the inflammation not coming back?
Yeah, so typically with most of the processes, say for bursitis or impingement, my course of treatment is going to be an injection of some steroid medicine and then send you to physical therapy. Because if I can get your inflammation down and the therapist can get your muscles strong around the shoulder and strengthen the girdle muscles that support the shoulder and take the pressure off the rotator cuff, 90%, about 90% of my patients will get better from that. Only operate on about 10% of patients that initially present to me with shoulder bursitis or impingement.
So if that therapy is supposed to be done at home after you are trained and it isn't done, then it's probably going to come back quicker.
It will.
Yeah.
It will.
if you have 2 different doctors that give
He's
you.
telling on you.
She's telling me to. If you have 2 different doctors that give you a shot, I guess both of them's cortisone, I don't know. One gives it to you right here, and one gives it to you back here. What is the difference?
Typically, if I'm going to inject shoulder from the back, I'm putting it above your rotator cuff, and I'm targeting the space where your bursa lives. So you have bursitis or even possibly a rotator cuff tear. So I'm trying to decrease the inflammation in that area and allow you to be able to go through therapy and regain your motion and strength that way. If I'm putting an injection here in the joint, I'm trying to treat a process that I know, or at least I think is coming from your joint. Arthritis, someone that has a labral tear that may want to prolong surgery or not do surgery right now.
Okay.
That would decrease the inflammation on the inside of the joint to allow you to be able to go through therapy and hopefully use your shoulder in your activities of daily living so that you're not painful.
So, let me see if I understand this. Okay, so arthritis and bursitis are like connected.
Not really. They sound alike, but bursitis is process that essentially is above your rotator cuff, so it's above the joint. So arthritis is in the joint here. So arthritis is wearing that cartilage out that protects your joint so that you're rubbing bone on bone. That's essentially what osteoarthritis is. What bursitis is a process typically that can start with some tendonitis of the rotator cuff that goes untreated and eventually progresses on to bursitis, or you can have a small injury to the shoulder, or for a variety of reasons you get some inflammation in the space between the rotator cuff and the top of the shoulder here, and that's where your bursa lives. And now it's not typically filled with fluid, but as you get the bursa inflamed, it fills with fluid and it becomes bursitis and becomes painful. So that anytime you raise your shoulder, whether that be out to the side, whether that be up, and sometimes just with rotation, you can cause pain just from that bursa being pinched in between the top of the humerus and the top of the shoulder here.
That's not
Shoulder
serious,
blade.
right?
It's not serious unless it goes untreated, and it can lead to more inflammation and then possibly rotator cuff tear down the road.
Are you trying to diagnose yourself?
She's trying to get out from coming to see me.
Mine started with bursitis and eventually became a torn rotator cuff.
Yeah.
A chromium process problems, but anyway.
And then you also have tendonitis.
That's correct.
There's that.
That's true.
Yeah.
There's a whole little consortium of things that kind of lead one to the other if go untreated.
My mother had all kinds of arthritis, and she would say, one of the boys are going to be coming to see me.
Arthritis.
One of those arthritis boys.
Arthur is not a good bedfellow. Once he gets, he doesn't let go.
Is tendonitis what you might have from your shoulder down to your elbow? If, you have to sleep on a pillow, with your arm in a certain position, like when it gets too cold and stuff like that? Is that something that has to be dealt with surgery, or is that something that's just inflammation? Is that what tendonitis is? It's inflamed?
Tendonitis is inflammation. It's an inflammation of the tendon itself. Now, tendon is connecting the muscle to the bone, so you can have tendonitis that is inflammation in the tendon itself, and you can decrease that. That doesn't necessarily need surgery. Now, if you're having pain from your shoulder to your elbow, it may not be your shoulder. It may be your neck, having a pinched nerve in your neck that causes radiation of that pain down your arm. Or it could be a variety of things in the shoulder or even the elbow that cause that pain that you're feeling from your arm, from your shoulder to your elbow.
All do.
I've got everything.
Well, very good. Well, thank y'all so much for coming out on this yucky night. I think everybody learned something. I hope that you did. So I don't know if you feel worse before you came or better. I don't know. Either way. But, feel free to follow up with Dr. Harkins. His office is right here, located on the hospital campus in the 2-story building just next door here. What days of the week are you here in Monroe?
I'm here on Mondays.
On Mondays. So very good. So call and get yourself an appointment if you're not already a patient of their practice, and then you can follow up with Nancy for physical therapy right in the same building. So we wish you all health and wellness, especially during this upcoming holiday season. If we can ever do anything to help you here at Clearview, please let us know. Feel free to leave your trash there. We'll clean up. No need for you to worry about that. And there's a few goodies out here on the table before you leave if you want to get some. So thank you.